Hi everyone, I'm Shuntaro Mukai, medical doctor of Department Gastroenterology and Hepatology, Tokyo Medical University in Japan. Now, I will discuss about a recent publication of GI, gastrointestinal endoscopy, which is prospective evaluation of a new biframe metal stent for the treatment of pancreatic corrections with video. This article describes the concept and the efficacy of a newly developed biframe metal stent dedicated for its guided drainage of pancreatic fluid correction. As you know, recently used guided transluminal drainage and the sequential direct endoscopic necrosectomy for pancreatic fluid corrections using a dedicated biframe metal stent, such as axial stent or nag stent, has been reported as a useful alternative to using one or more plastic stents or a conventional self-expandable bare metal stent. We think this biframe metal stent is well designed and very useful to treat pancreatic fluid correction, especially wolf necrosis after acute pancreatitis, which contains a large amount of necrotic tissue. However, do you think current available biframe metal stents are perfect? We don't think so. These stents have some limitations. Current dedicated biframe metal stents are divided into two types. One type is lumen opposing metal stent such as axial stent or spaxa stent, and the other type is fluid metal stent such as nag stent. Fluid metal stent has limitations in terms of a weak lumen opposing force leading to stent migration because of the flare flanges. This was shown in a multicenter national study conducted in Australia to evaluate fluid metal stent nag stent for its guided drainage, which included 54 cases, of which 4 cases, 7.4%, had stent migration during necrosectomy, and 6 cases, 11.1%, had spontaneous stent migration. On the other hand, lumen opposing metal stent has a lower stent migration rate, which is 1.1% to 5%. This data indicates the stability of lumen opposing metal stent appears to be better than that of fluid metal stent. On the other hand, lumen opposing metal stent has limitations in the case of a longer length between the gastric wall and the cyst wall because the stent length between biflanges is 10 mm. In this point, fluid metal stent has advantage because the stent length between two flanges of fluid metal stent is 20 mm or 30 mm. It is longer than that of lumen opposing metal stents. Thus, fluid metal stent is deployed safely in cases located at a long distance from the gastrointestinal tract. Recently, a new biflanged metal stent, Hanner stent, which has both advantage of the lumen opposing metal stent and the fluid metal stent, the so-called hybrid biflanged metal stent, has been developed. Here, we plan to prospectively evaluate this new Hanner stent for the treatment of pancreatic fluid corrections. In our clinical experience, the radial force of the Hanner stent is comparable to that of existing biflanged metal stents. The lumen opposing force of the Hanner stent may be weak compared with that of the axial stent because the length between the two flanges of the Hanner stent is longer than that of the axial stent. The Hanner stent may have a similar or better lumen opposing force than the spaxa stent because it has powerful flanges compared with the spaxa stent despite having the same stent length. The lumen opposing force of the Hanner stent is better than that of the nag stent, which has only fluid flanges. On the other hand, the stability of the Hanner stent is equivalent to that of the axial stent because the anchor flanges of the Hanner stent are designed to hold tissue layers tightly, similarly to the axial stent, preventing migration. Actually, stent migration occurring spontaneously or during necrosectomy was not observed in the present study. Since the stent body length is 20 or 30 mm, Hanner stent adapts to various locations of the pancreatic fluid corrections. In the present study, Hunter stent was deployed successfully with a median procedure time of 16 minutes and with no procedure-related adverse events in all the patients. Hunter stent was removed with no difficulty in 9 patients at median time of 48 days after treatment. This prospective study showed the new biflanged stent, Hunter stent, is technically feasible and safe for the treatment of pancreatic fluid collections. At the next step, we should study how we use these biflanged stents properly, including Hunter stent. Further studies using randomized control well-designed, adequately powered studies comparing the new biflanged stent with previous biflanged stents are required to validate its efficacy. Finally, we appreciate editorial board of GIE accepting our article and giving a great opportunity of GIE's author interview. Thank you.